Hi everyone, welcome. Um, just give me a hello in the chat if you can see and hear me all right, please. Perfect. Thanks, guys. I hope everyone is doing well and you've been kind of enjoying these free taster sessions. Um, so today, um, as you will hopefully know, we're going to be doing another hour session, and we've changed things around very slightly. So originally today's session was going to be radiology, but we've switched it with next week. So today we're going to be talking a little bit more about surgery and a surgical case, and next week is going to be more radiology based. So hopefully that's all right for everyone. We'll make a start very shortly. If you haven't seen the other sessions, guys, don't worry, you will be able to watch them back. They'll be available for a period of time to watch back. So I am going to share my screen. Just bear with me a second. Right. Hopefully you can see this now. I'm just going to make it full screen. So cool. Yeah. So for those of you asking, guys, it's going to be radiology next week. Cool. Um, can everyone see this? Okay. Just give me a thumbs up or a yes. Okay. Perfect. Right. Good stuff. Right. So as I said, today we're going to be talking about surgery. So as usual, guys, for all of the live sessions, we're going to be using menti.com. So you can either scan the QR code to join the Menti, or you can go to menti.com and type in the code that you can see on the screen now. For those of you who haven't used Menti before, it's just a way to keep the presentation a little bit more interactive. It lets you guys send in answers to questions, vote for things, and it just means it's not just me talking at you all the time. It means you get to do something a little bit. And obviously, online makes it difficult to do that, but I think Menti does generally help. So if as many of you can join the Menti as possible, that would be great. For those asking how long the session is, it's an hour, guys. You should have both running side by side, guys, because most me talking is obviously on the Zoom, but when there's a question, that'll be on the Menti. Cool. Right, another 10 seconds, and then we'll jump in. Cool. Right, let's go for it. So our kind of scenario for today is that we collectively, or you guys individually, you're a doctor working in the emergency department, so in A&E, okay? And the scenario that we've got is we have a 40-year-old patient, let's say it's a female, who comes into the emergency department with severe abdominal pain. So that's all the information that we've got. So the first thing I want to start with, and hopefully this is a bit of revision um, from kind of previous sessions. In what order do we want to kind of do these things? and people asking what analgesia is. That's just painkillers. Cool. Another few seconds. Cool. Right. So people have said taking a history first, then ordering a CT scan, then giving the patient some analgesia, and then sending the patient to the operating theatre. So I definitely agree that sending the patient to have an operation is going to be the last thing you do. And we have talked about before, and we'll talk about this again, that taking a history is really, really important to getting your diagnosis. So when you ask the patient questions, that gives you a lot of valuable information, which eventually gets you to the correct diagnosis. But in this patient, if someone's in a lot of pain, okay, it would actually be quite sort of kind and human to give someone painkillers first, wouldn't it? Rather than, make them answer lots of questions and then give them think something to help with their pain. You'd probably want to actually give pain relief first. So I know typically we've talked about, you go through this whole sequence of taking a history and then examining, then doing tests, and then diagnosing someone. And that is generally true. But if you've got someone who's in a lot of pain, it would make sense to kind of give them some pain relief first, make sure they're not writhing around in lots of discomfort. Um, and then do it. And by giving someone painkillers, you're not gonna cause anyone harm. There's lots of painkillers that you can give that are very safe for people. You don't have to give anything that could have side effects or or cause the patient harm. So I would probably argue in this case we want to give the analgesia, the painkillers first, but then yes, absolutely, we then want to take a history, and we'd obviously need to get a scan and make sure we know what we're dealing with before um, we send them to surgery. People asking about what about giving the painkillers. You obviously do need to ask them some questions before you give the painkiller, okay? So you need to make sure they don't have any allergies. You maybe want to ask a few brief questions about their medical history just to make sure you're not going to give them something that is going to cause them harm. But you only need to ask 2 or 3 questions to kind of ascertain that. You don't need to ask loads of questions. So now, moving on from that, going into the history, what questions could you ask to get more details about the patient's pain? So how can we be more specific to understand more about a patient's pain? If you can, guys, it becomes quite tricky because there are a lot of people in here for me to watch the chat and the Menti. So if you're sending in answers to the questions, please just send them in onto the Menti, please, if that's possible. Cool, give it another 10 seconds. Cool. Right, we'll stop the voting there. Um, cool. Right. So, few important questions. All right. So questions that I think that have been most popular, which I think are very, very relevant. The first one is about the location of the pain. And as we'll find out very shortly, that's a really key question. So where exactly is the pain, the location of the pain? So where is it? Where does it hurt? These are all asking the same thing, right? Which is good. And then the second question, which people are asking a lot, is the timeline of the pain, which is really important. So that does include when did it start or how long has it been going on for, the duration. So all of those obviously mean the same thing. But then more specifically, when we're talking about the timeline of pain, we want to understand, is this pain constant? Is it there all of the time? Or does it kind of come and go? Okay, because those are two very different things. And if it's coming and going, what kind of timeline is it coming and going on? So is it sort of there for an hour and then it's gone the rest of the day, or is it there most of the day and it's only going for short periods of time? So you want to understand that people asking what type of pain it is a really good question. So is it a sharp pain, a dull pain? Is it like a burning, shooting, all of those? Guys, just on the chat, people are just having like general banter on there. Obviously, look, there's nothing offensive in there, which is obviously fine. But please just try and keep it to stuff about the session, because the idea of the chat is for people to be able to raise issues or for me to kind of know what's going on if there's a problem. So don't just use it for all of the random chat, if that's okay, please. It's just there's too many people and I won't be able to keep up with it. Thank you. Cool. So going back to this scale of 1 to 10, so how bad is the pain basically, right? So on a scale of 1 to 10, how bad is it? If 10 is the worst and 1 is not that bad, on that scale, where is it? People also asking if it's happened before, which is a good question. Also asking kind of the type of pain. So we've got some good questions there, right? And to kind of break that down into a bit more of a structured way, then we can use an acronym called Socrates for that. So Socrates is an acronym which basically we can break down into these questions. So S is for site. So when we say site, so where exactly is the pain? So the location, which is a question you guys asked. And then onset is about when the pain began. So when did this start and kind of how long has it been going on for? And you also want to think about whether the pain came on kind of suddenly or gradually. Because obviously something that comes on suddenly can be something, going wrong quite severely, whereas something more gradual, usually you're less worried about it. Character, so what kind of pain is it? Is it sharp? Is it dull? Is it an aching pain? And then this is a really important one, which we didn't really get, but radiation. So does the pain, from where it is, does the pain move anywhere? That's quite important. All right. So for example, if the pain is in the tummy, does it go to the back? Does it go up to the chest? Does it go down into the groin? Those are common patterns of pain which are associated with certain medical problems. Alongside the pain, what other symptoms do they have? Which is another really important question. So associated symptoms. So could they have nausea? Could they have vomiting? Could they have a problem with their bowels? All of those things are possible. Okay. The timing. Okay. So we talked quite a lot about timing, but when did it begin? Is it constant or is it coming and going? And if it is coming and going, we want to kind of know sort of what pattern it is. All right. And then exacerbating and relieving factors. So what makes the pain better and what makes the pain worse? Okay. So could it get better with painkillers perhaps? Does it get better with eating or does it get worse with eating? Does it get better or worse in certain positions the patient might be sitting in? So thinking about all of these things, so a few people in the chat are asking the difference between onset and timing. So onset is about when the pain started and how it started. So for example, was there something in particular that they were doing and they suddenly felt the pain? Or did it come on more gradually over a period of days or weeks? So specifically about how and when the pain started, whereas the timing of the pain is more about what's happening now. So is the pain constant or is it intermittent, right? So is it coming and going or is it there all the time? And if it's coming and going, how often is it coming? How often is it going? How long does it come for? How long does it disappear for? So they're two different things. One is about how it started and one is about the timing now. Um, Severity, as we talked about, is just a scale on the 1 to 10. So cool. Salma asking about the why would you not do the scan before the history? That's a long answer, but go and watch the history taking session. We talk about it in a lot more detail there. Essentially, the history is really important to be able to narrow down what you're looking for on the scan, because if you don't know what you're looking for on the scan isn't very useful at all. But do watch the history taking session because that's where we kind of talk about that in a lot more detail. So let's kind of break down the information that we've got. Okay. So we've got a 45-year-old female patient. Okay. And the main thing that she's come in with is abdominal pain, so tummy pain. And specifically her pain is in the right upper quadrant. So it's in the right side of the tummy on the upper part just below the ribs. Okay, that's the area that we call the right upper quadrant. And when we go into more details about her symptoms, she's been experiencing abdominal pain, bloating, and indigestion for a few weeks now. Okay. The pain usually comes on after eating, especially if she eats fried, fatty food, stuff like chips. She's also noticed that her urine has become darker. The pain was excruciating, so really bad in terms of severity. And then she's decided to come into A&E because of that. Her past medical history is that she has hypertension, which means high blood pressure, and hypercholesterolemia, which just means high cholesterol. And she's had 2 previous cesarean sections, C-sections for having a baby. She takes a medication called Ramipril. She works as a dinner lady at a school. She doesn't smoke, and she just drinks alcohol occasionally. Okay, so that's kind of the overview of what she's come in with when you kind of take her history. So just a quick quiz question. This isn't something I expect you to know, but it's just to kind of for a bit of information. Does anyone know what Ramipril is? Yeah, good. So it is indeed a blood pressure medication. Okay, so she takes that for her blood pressure. Okay. So after that, so we've got that information. Okay, so based on what we know, what do you think we do next? And this is kind of how our decision making works in A&E as a doctor, because the first decision you have to make in A&E is, do we need to kind of admit this patient to the hospital, i.e., do they need to stay in for a day or two to have some further tests, or can we send them home and organize for them to have those tests from home? So maybe they come back to the hospital for a scan or a blood test, but actually they can be at home. So in general, people who are more unwell need to be admitted for further investigation because someone needs to, so someone needs to kind of supervise them, make sure they're not getting worse for their safety, or if it's less severe or we think they can be managed at home, then we can send them home and organize tests like that. And most of you are absolutely right. So I think this patient, she's got severe pain. It's been getting worse for a few weeks. It definitely makes sense for her to have some further tests before you send her home, because it would be very brave to send someone home without doing any tests at all. So what kind of things can we do next after the history? And this is a recap of what we kind of talked about in the history taking session. But in A&E, it's always important to do what we call observations or vital signs. So this is things like heart rate, blood pressure, respiratory rate, so how fast they're breathing, oxygen saturations, which is kind of how well oxygenated their blood is, their temperature. And these things kind of help us to detect if someone is kind of acutely unwell. So acutely unwell is someone has quite a serious kind of illness, which might harm them or make them unwell quite quickly. So when someone has something like that, these measures often show abnormalities quite early on. So that gives us a clue as to just how unwell she is. We can do blood tests to look for kind of markers for infection. So the full blood count and inflammatory markers will go up if a patient has an infection. And we can also look at things like the liver and the kidneys and how well those organs are working. There can also be other tests where we look at the urine, or we can kind of send off other samples of fluid like spit, mucus, poo samples if we need to. And then obviously we can do imaging as well, which is different types of scans. So we want to kind of work our way through all of the relevant tests that we might need to do. But remember, the history is the key at the start to kind of narrow down what it is we might want to do, and then we do our tests accordingly. So just to recap, so we would want to take a history, understand what the patient's symptoms are, and remember at the end of the history, you kind of come up with something called a differential diagnosis. So remember, in the history taking session, we talked about this, where you aim to have a list of a few things that the patient might have. And then from there, you use your other tools to kind of rule in and rule out those possibilities. So the observations, as we said, are to kind of detect if someone is seriously unwell. We can also do physical examinations where we kind of listen with a stethoscope, feel with our hands, poke around to see if the patient has pain in a particular place. We do scans and further tests, and then usually towards the end of getting those results, at that point, as an A&E doctor, we have a decision to make, because you can then either send the patient home to then come back to the hospital to have further tests, or if they need to stay in hospital, you need to refer them on to a specialist who will then look after them within the hospital. So they either need to be referred on to a specialist and admitted into the hospital, or they need to be discharged home. It needs to be one or the other. So before we kind of go on, I just thought it'd be useful to do a little bit of an anatomy recap. Because remember, this patient came in with pain, which was in the right upper quadrant, which means kind of just up here in the upper right part of the tummy. And as some of you correctly pointed out in the chat, that's where the liver is. So what I'm going to do now is share a different screen just to go through a little bit of anatomy, because I think it helps to understand where different things are. So right, can everyone see this, guys? Awesome, cool. So this is just an anatomy model, okay? Um, and what I've got here is I've kind of removed all of the stuff off this body, apart from what we call the kind of the digestive system. So the digestive system is everything that runs all the way from the mouth down into the intestine and out to the anus, so where your poo comes out. So if we kind of follow the anatomy of this, I think it's quite helpful to understand where things can go wrong. So obviously food comes in through the mouth, you've got your salivary glands here, and then after that, it goes into the food pipe, which is what we call the esophagus. Okay, I'm going to zoom into that in a second. There we go. So you can see the food pipe here. It's kind of coming down through the rib cage. Okay, obviously your lungs would normally be there. For those of you asking what this is, so this is an app called Complete Anatomy. You have to pay for it though, so it's not kind of a free app, but it is available to everyone if you wanted it. And then you've got your esophagus, okay? And from your esophagus, this organ that's highlighted in green right now is your liver. I'm just going to take this away for a moment just to be able to see what I'm doing. But what you can see is the esophagus here then joins into this pink organ, which is kind of like a bean shape, and that's your stomach, okay? So your stomach sits just at the bottom of the ribs, on the left side. Okay, so when someone has pain on the upper left part of the stomach, one of the organs that we need to think about where there might be a problem is the stomach. And this yellow stuff around it is just fat. Okay, now I'm just going to get rid of that and come back to it later as well. Right, what you can see here is as we come out of the stomach, we have this red pipe there, okay? And that red kind of pipe as it comes out, that is the first part of your small intestine, okay? So the small intestine, this first part is actually called the duodenum. So as you can click on that, that's the first part of the small intestine. And then what you then see is, again, if I remove this, just to move it out of the way, you can see that the small intestine becomes this big bag of worms that you can see in the middle. So that kind of whole wiggly bit right in the middle, which looks like a bag of worms, that is your small intestine. Okay? So that's kind of your small intestine. That's the first part where the food passes through. And then after that finishes, sorry, just give me 1 second. I'm just going to restore this. After that finishes, you then get your large intestine. So right down here, where I've highlighted there, that bottom right part is where your small intestine becomes your large intestine. And that is in the lower right portion of the stomach, of the abdomen, sorry. So that's something called your cecum. And you also have your appendix sitting here just behind, okay? You can't see it too well on here, but can you see that sort of wiggly thing right round the back? I don't have a cursor on this because it's on an iPad, but can you see that that thing that looks like a worm poking behind where the intestine is? I'm just trying to get this to go. 1 sec. Oh crap! What have I done there? There we go. Sorry, I'm back. So you can see round the back. There you go. That thing right in the middle. That's your appendix. Okay, so a lot of you will have heard of a condition called appendicitis. So appendicitis is when the appendix becomes infected and inflamed, and that's the little thing there. So that's why when people get appendicitis, they tend to get pain in the lower right part of the stomach because that's kind of where the appendix is within the body. Okay, so just thinking about different areas where people could get pain. Remember, we said upper left, it might be the stomach, lower right, it might be the appendix, and then the large intestine kind of continues to travel all the way around before it exits. So normally a problem in the bottom left is a problem to do with the large intestine. But hopefully that gives you some orientation of where the different organs are. Now, remember, our patient has pain in the upper right part of the stomach. So let's focus in that area now. So if we look in the upper right, this big organ here that's highlighted in green right now, that is your liver. Okay, so a liver is a very big organ. It sits in the upper right part of the stomach, and obviously problems with the liver could cause pain in this area, absolutely. But if we hide that and look behind the liver, does anyone know in the chat what this green organ is that there? I've just highlighted it. Gallbladder. Good. So that's your gallbladder. So problems in the upper right could also be the gallbladder. So let's get rid of the gallbladder now and see what else is here. Let's hide that. That's the first part of the small intestine. Does anyone know what this yellow organ there is? The pancreas. Good, very good. So that is your pancreas. So another thing that can cause problems in the upper right part of your stomach and pain in that area is the pancreas. So actually knowing your anatomy becomes really important, doesn't it? Because if you know what organs are in a particular place of the body, that can be quite helpful for you to then figure out what can cause pain. So even without really knowing too much about medicine, if we just know that in the top right part of the stomach, what organs have we got? We've got our liver, we've got our gallbladder, we've got our pancreas, we've got our small intestine. And if we know those things are all there, then there's a pretty good chance that, you know, one of the things, one of the cause is going to be one of those things, is what I was trying to say. Sorry. Cool. So that was a bit of anatomy. Let me reshare my normal slides now. And as you can see, this is kind of showing a very similar thing, okay? Just splitting it into kind of 4 quarters and being able to see what's in the different parts. Cool. So the way we can kind of, really figure out where the problem is through a CT scan, okay? So a CT scan is like one of these scanners. It looks like a giant donut and someone goes through the middle of it. And it uses lots and lots of X-rays, which are kind of beams of radiation which shoot through the body and to the other side. And it shoots lots of those in different directions to create a 3D image. And CT scans have good things and bad things about them. So what's good about a CT scan? So it's non-invasive. What that means is you don't have to kind of put anything inside the patient's body. There's no cutting, there's no needles, there's nothing that needs to actually go inside the patient, which makes it, less likely to cause complications. It's very fast, okay? So you can do a CT scan within about 5 minutes. It's really quite quick. And because it's not invasive, you're not putting anything inside the body, it's quite safe as well. And because it's quick, it's readily available, it's cheap, and it's specifically good for looking at bones. Okay, so if you want to look at bone, CT scans are really good. The problems with CT scans is you're using lots and lots of X-rays, and X-rays are radiation. And if you give someone too much radiation over a period of time, there's a risk of causing damage to their tissue. So you don't want to give this, don't want to do it without a good reason to do it. And it's also not too good at looking at the soft tissues. So it's good at looking at bone, but things that aren't bone, like all of the different organs, intestines, fat, muscle, all of those types of things, um, those things don't show up as well. But the reason we do CT scans in A&E as opposed to MRI scans, because MRI scans tend to give us more detail and better pictures of the soft tissue, but MRI scans take a really long time. And if you think about A&E, you need to get stuff done quickly, and you've got loads of people who need scans. So the biggest thing that you need in A&E is speed, and that's why we do CT scans most of the time in A&E, even though an MRI would give us a better picture a lot of the time. So you guys have got you should be able to see this this on your screens as well. And this type of question basically allows you to kind of try and put a pointer on where you think the problem is. Okay. I'm going to hide your responses so everyone can kind of look in different areas. So don't worry, I will go through what this is showing very shortly. Okay. But this is what a CT scan looks like. So just to start giving you guys some orientation, the way a CT scan picture works is this is like a cucumber slice through the patient. Okay, so if you imagine the patient is a cucumber running from head to toe. Okay, imagine they don't have arms and legs. It's easier because then you don't have to worry about the arms and legs because we're just looking in their abdomen. So if you imagine they're a cucumber, this is a slice through them, and we're looking at the cucumber slice. And the way they're orientated is they're lying on a bed, okay, and their head is away from you, and their feet are towards you, and they're looking up at the ceiling. Okay, so just to re-emphasize that, they're lying on a bed on their back, so they're looking up at the ceiling. Their feet are towards you, and their head is away from you, and so you're looking all the way down, and you're taking a slice. Okay. So if you think about how that patient is orientated, hopefully it then makes sense that this, where my cursor is at the moment, is the back of the patient. And therefore this white thing, which looks a little bit like, I don't know what it looks like a bell, with a little pointy thing at the end. This is their spine. Okay, this is one of the vertebrae. And this is the front. Okay. Now, remember, this is a 3D image, but we can only look at 2D slices of the image. So we can only look at one slice at a time. Okay, you can't actually reconstruct it in 3D very well. You need to scroll through slice by slice. Okay, so this thing right at the back is the bone. So that's their backbone, their spine. And therefore, this is the front of the patient. Okay, now on a CT scan, everything that's white is more dense. So the things that show up white are bone and fluid. So things like blood shows up white. So this is white because it's bone. The things that show up black are the things that are least dense. So the least dense thing that you can really think of that might be in someone's body is air, isn't it? There's not really much that's less dense than air. So this black thing right at the front, this is air, okay? So there's air in their abdomen, but actually it's very normal to see air on a CT scan because this is within their bowel. So within your bowel, within your intestine, it's normal to have air in there. Okay, like that's why we fart, isn't it? Because you're getting rid of air from in there. So it's normal to have air in there. So actually, that bit being black isn't too much of a problem. So let's see what you guys said. So there's pointers everywhere. A lot of you have pointed to this thing. A lot of you have pointed to this thing. So the 100 of you here are actually absolutely spot on. So what you can actually see on here is this thing here. So if you see this grey object where it's kind of like a big oval type thing, that is your gallbladder. But normally the gallbladder should be a lot smaller than this, okay? The gallbladder is quite a small organ. It should only be sitting kind of just at the front here. So it's much bigger. It's basically been blown up like a balloon. The wall of the gallbladder is quite thick, and it's got fluid within it. And you've also got this thing here, this white thing, which is something we call a gallstone. Okay, so some of you might have heard of gallstones before, but basically the way to kind of understand this is to think about what the gallbladder does and a bit about the anatomy again. So what's the function of the gallbladder? The gallbladder stores bile. Okay, so bile is a chemical that's made by our liver and stored within our gallbladder. And the function of bile is to help with the digestion of fats. The bile does something called emulsifying, which is to break down the fats, and then they get digested within the bowel. Okay, so the job of the gallbladder is to store the bile, keep it concentrated, and also maintain the right pressure within that biliary system. So what generally happens is the liver, which is this big organ at the top, that makes the bile, okay? And then the liver sends the bile down this passageway, which is called a hepatic duct. And then it kind of turns around and goes back up here into the cystic duct and into the gallbladder, okay? And the gallbladder stores the bile. And then when you eat fatty food, your body sends a signal to your gallbladder to contract and to squeeze out that bile. And that bile comes down the cystic duct, then down the common bile duct, and into the duodenum, which is the first part of the small intestine. Okay, so that's kind of the normal process. Now, what can happen in gallstones is that you get that bile crystallizing into these solid stones where they're kind of made of a kind of crystallized version of that bile. And that can happen for a number of reasons, but we know it happens a lot more in people who eat a lot more fatty food because probably they're producing too much bile and there's too much stress on their gallbladder. It also happens a lot more in females and people around, kind of females who are kind of in middle age as well, specifically tend to get gallstones. But obviously being overweight and eating fatty foods will increase your risk of that. And once you get a gallstone in there, it gets stuck in one of the ducts. And that's once it gets stuck, everything is blocked. The system is blocked. And once the system is blocked, your gallbladder is trying to contract and push bile out, but the stone is pretty much blocking the way. So if you imagine where this little line is, if you've got a stone just lodged in there blocking it, the bile then can't exit the gallbladder properly. And what happens is that bile is just sitting there, it's pooling for a long period of time. What happens there, when the bile sits there for a really long period of time, it starts to brew an infection. Okay, like if you imagine anything is stagnant, it's not moving, it's really high risk of getting an infection there. So what can happen from that is you can get this thing that we call acute cholecystitis. So what is acute cholecystitis? Like I said, it's where you get a gallstone that's blocking the duct. So this is a picture of that gallbladder and that duct here. It's blocking the duct. you get lots of pooling of infection within the gallbladder because you get bacteria going in there. And then depending on what complicates from there, the gallbladder can burst, the bacteria can move into the blood and cause infection all around the body, and that's what we call sepsis. So there's lots of kind of complications from that. Okay, the worst case scenario is the gallbladder can die off and then burst, and people can die from this as well. Okay, that's kind of what's going on here. This patient has a gallstone which is lodged into the cystic ducts coming out of the gallbladder. The gallbladder's become blocked. All the bile is sitting in there and it can't move. Bacteria get in there and cause an infection, and that's why she's feeling a lot of pain. Now, if that infection was to get worse and spread around the body, she would start to feel a lot more unwell. She might get fevers and shivers and sweats like people do when they get infections, or sometimes the gallbladder might burst, in which case her pain would get even worse because the gallbladder is obviously burst. Okay. So that's kind of an illustration of what's going on. And if we flick back to the CT scan, this thing up here, this grey thing, that's the gallbladder. But remember, you're seeing a slice through the gallbladder. It's a cucumber section. And what you can see is it's much more big, it's much larger than it normally should be. You can see that gallstone sitting in there. The wall is thickened, and actually you can see it just doesn't look very happy at all. So, what do we think we need to do next? Okay, so one person has said send the patient home. Okay, everyone else is kind of in between observing them for a few hours and sending them to the operating room. And both of those are correct. Okay, there's not a right and wrong answer. So what we want to do first is we need to treat this person's infection. Okay, so remember, cholecystitis is an infection that's kind of brewing within the gallbladder. So what we need to do is kind of give antibiotics to treat that infection. And we need to just let things settle down a little bit. Now, that can take hours or it might take days, depending on how unwell they are. But we don't want to do the surgery while someone's got a really bad infection in the gallbladder, because if you try and cut it open, it's going to be really messy. Everything is inflamed, and the surgery itself is very difficult. Okay, so actually what we choose to do is to try and settle the infection down a little bit first with antibiotics, and then go back in later to do the operation. But the operation is something that we call a laparoscopic cholecystectomy. So what does that mean? Laparoscopic means keyhole surgery, and cholecystectomy means removal of the gallbladder. Okay, so this is a keyhole surgery to remove the gallbladder. Because remember, the gallbladder is actually an organ that you can do without, because it doesn't make the bile, it just stores it. So your liver can also take over the gallbladder's job of storing the bile. So what happens is you take out the gallbladder, and then the liver makes the bile and decides, okay, well, I'll just store it as well. So you don't need your gallbladder, you can do without it. Your liver can do the job. So this is a picture of a gallbladder full of gallstones. So you can see they literally just look like kind of stones, like marble type things. So that's lots of gallstones. So that's bile that's crystallized. So remember, this is an operation, and surgery is something where, you know, we have to be very careful, because surgery is kind of, you know, it's quite exciting a lot of the time. It looks like we're doing lots of really cool stuff. But surgery is also the most risky thing that we do in medicine, right? It has the most risks compared to anything else that we do. And when we're deciding to do an operation, we need to weigh up what are the risks of doing an operation, and what are the benefits of doing an operation. So in someone like this, the benefits are that, you know, we get rid of her gallstones. It stops her having pain on a day-to-day basis. It stops her having another infection in future. So there's obviously good advantages, but the risks are that, you know, when we cut someone open, we can cause bleeding, we can cause infections by doing that. There's the risk of the anesthetic because you need to put someone to sleep, and that can have cause problems for the heart and lungs. Obviously, people generally have pain after an operation because you've cut them, and that can often take weeks to settle down, and that can mean time off work and all of that kind of thing. And there's also an increased risk of people getting blood clots in their veins in the few weeks after they have an operation as well, and that can be quite a serious problem. So there's quite a lot of risk, and obviously, you know, alongside that, there is always the possibility that things can go wrong during an operation where you cause damage to other organs and to structures that you're not intending to touch, but you might do by accident. So, you know, this isn't something to take lightly. Now, the good thing about keyhole surgery, remember, and what we do for the gallbladder is a laparoscopic or keyhole operation, is it does help to reduce some of these risks. So, you know, the patient generally, because you're going in with little incisions, which I'm going to show you in a minute, there's less pain, there's less risk of infection. They don't have to stay in hospital for as long, and they get back to their normal activities quickly. So there's still quite a lot of risks involved, but it's less because you're doing keyhole surgery. So I'm just gonna we'll go back to these questions in a minute. I just want to show you something first. So let me just stop sharing and bring something up on my phone. Right, just give me a second. Right, hopefully you guys can see this now. So this is my phone screen. And this is kind of like a surgery simulator. So I'm just going to show you what kind of happens in a keyhole operation like this. So obviously what we've got here is the patient kind of positioned on the table. And what happens is we kind of obviously make a cut. And I'll tell you what this is afterwards, guys. You can have a play around with it. Um, Obviously, you make an incision in the skin, so a small cut. Okay. Then they use these retractors to kind of open it up. You kind of make cuts into the deeper layers. So all they're doing there is they're kind of cutting through the different layers of the skin. Once you've kind of, you know, you're in the abdomen, this is a bit gross. So if you're eating, you can turn off for a bit, but you kind of you basically stick a finger in to kind of widen it up. And just make sure there's plenty of room. And then what happens is you put the port in. So this is kind of the main port where the camera goes. Okay, so and this is kind of just next to the belly button. And then basically through this, they pump in a lot of air to blow up the tummy. So now the tummy is blown up, it's full of air, and that gives you more room inside to be able to work in. Okay. And then at this point, you change the patient's position to make it easier for you to have the room to work. And then now this is then putting the camera in. Okay, so this is the camera going inside. Okay, and now they're looking around inside the abdomen. So this is inside the tummy. That yellow stuff is all fat that you can see. So all of that stuff is fat. And now what they're doing is they're putting in the other port. So remember that the idea of keyhole surgery is that there's one big port which has the camera in, and then you have two other little ports where you put your kind of instruments through. So what they're doing now is they're making the incisions for the other ports. So you'll see in a second something is coming through that wall. So that's where they've just put in the other incisions where the instruments will come in. So that thing there is the gallbladder. Okay, so you can see it sitting just underneath the liver. And there's fat on the other side of it. So what they're doing is they've picked up the gallbladder, but what they now need to do is they need to kind of dissect it away from the liver, because you obviously don't want to take the liver out, okay? So you need to kind of cut that away. So what they're going to do is they're going to try and grab the right part of it and kind of get underneath it and sort of have a good look around at it. And now they're going to start dissecting, which means kind of starting to cut things away to be able to take the gallbladder out. So what are they doing now? They're cutting through some of that fatty tissue. And they're using a sort of an instrument which kind of helps to burn through the tissue to kind of help cut it. Okay. So the next few steps is just more cutting. So they're cutting through the fat around the gallbladder, making sure they're cutting off all the blood vessels because you don't want it to bleed. And the really important thing here is obviously you don't want to damage the liver at all, because the liver is a really crucial organ, really vital. And if you cause damage to that, you're in big trouble. So that's why that's the thing you really, really want to avoid. Okay, so now what you can see here is they've cut through the fat, and the two things that you can see there are the cystic duct. So that's the duct that the gallstones used to go through before. And then next to it is the artery. So that's the blood supply to the gallbladder. So what are they going to do? They're going to burn off that artery. And because it's burned shut, it's not going to bleed. They're going to put clips in to help reduce the bleeding. So this is so the artery doesn't bleed too much. And they're going to do the same for the duct, because we don't want all the bile leaking out. So they're putting a clip there to make sure that it doesn't all leak out. A third one for good measure. And now they're going to cut the artery, okay? Because now we've burnt it shut, we've clipped it shut, so we're quite confident it's not going to bleed. So we cut that, and then we also cut the cystic duct, so the thing where the bile comes out. Now we have the gallbladder that's separated out from everything. So we can kind of do that, but then we need to cut it from the other side. So remember, the gallbladder is attached to things around it from the whole way around. So all they're now doing is they're now cutting away the other sides of it. and then it's separated. Now what they're going to do, which is this is quite cool, they put in a little tiny bag through one of the ports. So it's literally like a plastic bag. They're going to put the gallbladder into this little bag. And pull it out. And that's basically the end of the operation. All they're going to do now is tidy up. So that was a gallbladder operation. That's how you take someone's gallbladder out with keyhole surgery. So hopefully you got a bit of an insight into kind of how that works. So guys, that app is called Touch Surgery. So you can just download it. You just need to sign up to it, but you can look at that again if you want to. And that's a free app. So it's called Touch Surgery. I am now going to just do a few quiz questions before we wrap up. So let's get everyone on the Menti. The app is called Touch Surgery, guys. I'll put it in the chat. Right, let's go. So which of these is not a risk factor for gallstones? Nice, so most of you got it. So remember, having a diet that's high in fat, being unhealthy is more likely to cause gallstones, okay? What is the primary function of the gallbladder? Good. It stores bile. Remember, the liver makes the bile and the gallbladder stores the bile. Okay. Good. So we remove the gallbladder. Okay. Endoscopy is where you do a camera inside, like inside the bowel, okay, to remove the stones. But remember, guys, we don't remove the stones because if we remove the stones will just come back. So we remove the whole gallbladder, not the stones. The gallstones, yeah? So which of these is a complication that we get from gallstones? So hypertension, guys, is high blood pressure. So remember, that's obviously got nothing to do with the gallbladder. Neither is disease of your coronary arteries. Osteoporosis is where you have brittle bones. So remember, cholecystitis is the most common complication of gallstones, where you get an infection within the gallbladder because one of the stones is blocking the duct, so the bile can't get out. Ooh, sorry, I go back. I think I missed that one. So what is the name of the operation that we just talked about? Good. So it's a laparoscopic cholecystectomy. Very good. So someone just asked what's the difference between laparoscopic and endoscopic. So laparoscopic is keyhole surgery, whereas endoscopic is just putting a camera down through the mouth into the body or up the back passage into the body. So endoscopy is what we do to look inside the bowel, but it's not a surgery. We don't actually use any operating. We just have a look inside. Don't worry about this one. I didn't actually talk about this. We'll skip that. Right. So then last few are a few pictures. So these are pictures of an ultrasound scan of the gallbladder. And oh no, this is the thing I was trying to skip. Sorry, guys. Right. This is the last few are pictures of the gallbladder. And I think the question is going to be whether you can see gallstones or not. So what you can see here is this big outline, the black kind of blob with a kind of gray thing around the edge. That's your gallbladder. Okay. And this is an ultrasound scan, so it's different to the CT scan we looked at. The picture obviously looks quite different, but you can see those gallstones sitting at the bottom there. The image should be on your phones, guys, the thing that you're looking at. Is it not there? I apologize if it's not. Oh, sorry, guys. My fault. I thought there was a picture on there. This one does have one. So this is a CT scan like the one we looked at before. So see if you can remember where the gallbladder would be. Give you a clue. The gallbladder is that dark grey thing on the top left of the image there. And this bigger is sitting underneath the liver. So the question is, can you see any gallstones there? Good. So there's no stones on that, right? So I'm just going to show you the picture again. So if I go to the picture, where my cursor is, that's the gallbladder. Okay, so remember, this is a cucumber slice. The patient is lying on their back looking up at the ceiling. Okay, so this is their back, this is their front. And this here is their liver, this grey organ right around there. And the slightly darker grey thing just inside it is the gallbladder. Okay, now if you saw a stone, the stone would be visible because it would look different. So you'd see that there's something in the gallbladder which looks different. And because the stones are kind of made quite dense, they would show up quite bright and white. Okay, so bear that in mind now. And then last question. Yeah, so good. Most of you got that there were lots and lots of stones there. That one had loads of stones. Okay. Good. So, hopefully that was interesting. So we kind of covered quite a lot of ground there. Um, where we looked at kind of a bit of a history, what how we would assess a patient coming into A&E with tummy pain. We looked at some different types of scan. We looked at some anatomy, especially around the gallbladder and the bowel, and we looked at a bit of surgery as well and what that would look like. Um, Hopefully that was interesting for you guys. We do have obviously another session next week on Saturday. So that will be with my colleague Osama, who will be talking more about scans and radiology. And then I think we will also have one more evening session as well. So yeah, hopefully that's been interesting, guys. And if you have any questions, send them in. But otherwise, take care, and I will see you all very soon. Take care, guys.